is the lecture that goes with the reproductive PowerPoints. So at the beginning of the lecture, we're going to talk about oral contraception. And to understand how that works, you have to understand the hormone fluctuations of the menses cycle. So the standard thought about this would be the average or usual menstrual cycle. So day 0 is the day that the person starts to have their menstrual bleeding, which typically is 7 days. During that time, the estrogen level starts to increase, and during that time, the follicle, the dominant follicle, the one that will be part of ovulation, gets larger and also begins secreting estrogen. And so by the time we get to mid-month, when ovulation is supposed to take place, estrogen is high, ovulation takes place, the follicle that's left behind is called the corpus luteum, and that secretes lots of progesterone. And as time goes on and the corpus luteum gets old, the progesterone that is allowed to release decreases because it's not the same as it was in the very beginning. And if there's no fertilization between the ovum and the sperm, then the progesterone level decreases and the next period starts. So it's the beginning of the estrogen that starts to prepare the endometrial layer, and then the second half, the progesterone makes it thicker and gets the uterus ready for conception, and then obviously doesn't happen, and so the menstrual cycle takes place. The way birth control works is that if you take a constant low level of estrogen, progesterone, then you don't have a dominant follicle, you don't have the hormone swings of the usual menstrual cycle, and you prevent ovulation in that way. So oral contraceptives don't prevent implantation of a new gamete. They don't stop what is called abortifacient. That's not that. It just stops ovulation, so you can't have conception. So the two different types of oral contraception we have listed are monophasic and triphasic. There are many, many, many types of contraceptive medications. They vary in which preparations of estrogen and progesterone they use, in what's the dose of either of those things. And the other big thing that is different amongst them is if they're monophasic or triphasic. Monophasic means that every day is the first week, second week, and third week that you're using your pill pack, which looks like a month. It has 28 pills. That those first 3 weeks you're taking hormones that are the same dose every single day. And then the last week, when the woman would have her withdrawal bleed, there would be just sugar pills, just to mark the time, so it helps to remember. So the triphasic means that there's a different dose each week. So the first week typically has the highest dose, and then the second week gets lower, and the third week is the lowest dose. So sometimes people use that and they might need hormone manipulation because they have more bleeding in the beginning of the cycle, or they have breakthrough bleeding, so you have to change the content of the hormones. So that's the big difference between monophasic and triphasic. But all birth control does is prevent the fluctuations in hormones so that you don't have ovulation. So there are complications with birth control. It's certainly a lot better than it used to be because the content or the concentration of estrogen has decreased in the pills over the years. But the biggest complications have to do with potential liver toxicity, hypertension, and clot development. Because anytime you manipulate estrogen in the body, add more or add it in a different way than the body is used to, that is typically the complications. So the way to remember that is an acronym called ACHES that people generally use. And A for aches is abdominal pain, which is indicating the liver, which is often the first sign that there's a problem. C is chest pain, potential heart attack. H and E are headaches and eye problems, which could mean hypertension or stroke. And S is leg pain, which could mean you have a clot in your leg. So it's a way to remember liver issues, hypertension, and clot issues. There are contraindications and cautions for using oral contraceptives that have to do with the issues that can occur, their adverse effects, the aches. So we have to be sure that the person doesn't have a history of clots, stroke, or CVA, and we want to be sure that the patient themselves isn't at increased risk for clots, strokes, or CVA. And people who are older than 35 who smoke and already have hypertension are at high risk and probably should consider not taking oral contraceptives. Because it's a change in the daily estrogen content in the body, if the person has a history of estrogen-dependent cancers in the breast or the endometrium, they probably shouldn't take it. If they have a family history of breast cancer or endometrial cancer, they should consider not taking it. The other issue is obviously you don't want to take it if you're pregnant because you are ingesting more estrogen and progesterone daily, which could feminize or change the genital development of the unborn child. So it is a pregnancy category X. There's lots of interactions, as we know, as we've studied throughout the semester. Definitely with antibiotics can decrease the effectiveness. Some of the anti-seizure medications can decrease effectiveness. The last two medication interactions are the kind of people that really shouldn't be on oral contraceptives, but because it does decrease the effect of warfarin, so if you're someone that has to be on warfarin, you probably shouldn't be on oral contraceptives. And it does increase the risk of hyperkalemia if someone's taking an ACE inhibitor. So those are some other interactions to keep in mind. And because people who take birth control pills have to remember to take a pill every day at the same time, you have to be sure that you're the kind of person that can do that. Even if you are pretty good at maintaining a schedule, it is easy to miss a pill. And if you do, the main question then becomes, is this still effective? Will the medicine still prohibit or inhibit ovulation? So if you miss one pill, the thought is you can take it as soon as you remember and you should be fine. So perhaps you take your schedules to take your pill every night at 2200 before you go to bed. And Monday night you took it, but Tuesday you forgot. And Wednesday you wake up in the morning and you're like, oh, I forgot to take it. So you could take it then, or you could wait to the evening on Wednesday when you would normally take it and take 2 at that time and not worry. If you miss 2 pills, so you miss Monday and Tuesday, on Wednesday you should take 2 pills, and on Thursday you should take 2 pills, and then Friday, keep continuing on with your regular daily pill and you should be okay. But if you miss 3, then you can't be certain that you won't ovulate, and so you should, stop and restart a pill back, and then in 7 days you would be okay. Or you should go through that, if you don't want to waste the pills or whatever, go through that cycle, but know that you have to use a backup mode of contraception. At a certain point in a woman's life, the ovaries stop producing the same amount of estrogen and you stop having prominent follicles and going through the menstrual cycle. So the definition of menopause means that the person hasn't had a period in a year. This is usually gradual decrease in estrogen. So it starts out usually with some cycle irregularities before menopause occurs. The role of estrogen in a woman's body is many things, which is why people who are going through menopause have a lot of symptoms. So estrogen is part of the sleep-wake cycle. So once you lose or have a decreased amount of estrogen, there tends to be issues with insomnia. It's part of mood, so people can have depression or anxiety with a decrease in estrogen. It's part of temperature regulation, which can explain some of the hot flashes or issues with that. It's very necessary for bone health, as we talked about with osteoporosis, and so lack of estrogen increases the potential for osteoporosis. It's part of lipid metabolism and cardiac health, because usually after menopause that women's cardiovascular risk equals a man's. It is part of maintenance of the vaginal and vulvar tissue, keeps that tissue healthy. There's decreased estrogen, and that tissue becomes thinner and more dry, is more prone to injury. The woman's more prone to urinary tract infections and can have issues with painful sexual intercourse. So people will sometimes consider hormone replacement therapy in order to try to minimize those symptoms. So since I've been in practice, which has been a while, the pendulum has swung back and forth between whether or not to use hormone replacement therapy. When I first started, it was everybody should be on hormone replacement therapy. Women need to protect their hearts, and there's no reason why anyone shouldn't do it. Then there was a big nurses' health study that came out that a lot of women who were on hormone replacement therapy seemed to have an increased risk for breast cancer, and it didn't do as much for their lipid profile and their cardiac health as was thought. So it was like nobody should be on hormone replacement therapy anymore. Later, people re-looked at that women's health study and thought maybe some of the correlations were not as strong as they thought they were. So the current thinking is that the best way to manage hormone replacement is based on symptoms. It's not a have to. It has to do with how the person feels. And if they're going to be on it, it should be at the lowest dose for the shortest amount of time, especially in the very beginning of menopause when sometimes the symptoms are a little harder to deal with. So there are several preparations: oral, transdermal patches, vaginal inserts or creams, or a ring. Our prototype medication is Premarin, which is conjugated equine estrogen. It literally gets its name because it's pregnant mare urine is how it is made. So the side effects of hormone replacement therapy are similar to that of oral contraceptives, and our concerns are a little bit similar as well. So anyone who is at increased risk for stroke or cardiovascular disease, we have to worry about giving a more constant level of estrogen, as that could increase their clot risk. So we have to worry about hypertension and stroke, MI, and previous clots. If the person has a personal or family history of breast or endometrial cancer, again, you have to consider maybe not doing it, especially if those tumors were estrogen dependent. Contraindications: obviously, if you're not in menopause, you shouldn't be using hormone replacement, certainly pregnancy. If the person who is on hormone replacement suddenly develops vaginal bleeding, it's possible that there's an overgrowth of that endometrial layer from the estrogen, and maybe they have hyperplasia, but they could be starting to develop cancer. So that's a reason to stop and be evaluated by a gynecologist. The patient has a history of heart disease, as we said, cancer, or liver disease. And then there are some drug interactions with phenytoin and warfarin in particular. The next part of this lecture are medications that either can support and augment labor or can stop labor. So a woman who is having issues with either their labor is lasting too long, or it's not, they've been pregnant for over 42 weeks and we're worried about the fetus. They have been in labor for a really long time, but that doesn't seem to be progressing. Their bag of water's broke. And after 24 hours, we start to worry that the woman will be at increased risk of endometrial infection. Those are reasons to potentially start the patient on an IV infusion of oxytocin to support labor. So oxytocin is our example of uterine stimulant that we have to worry about for class. So oxytocin is actually a naturally occurring hormone in the pituitary that responds to, and there is a release of oxytocin with pressure on the cervix from the fetus. So here's how obviously not the best drawings in the entire world, but this would be the uterus. So the cervix is normally about 4 centimeters. It's a thick muscle, and the developing fetus is in there connected to the placenta. And this person is not ready to give birth. The baby isn't in the right position, and the cervix is not thinned out. Later on, the cervix thins out, kind of pulls aside so that the opening of the uterus dilates to allow the infant out, and the head is down and positioned to go through the mom's pelvis. So the baby has to be in the correct position, and the cervix has to be thinned out and dilated in order that the baby can be delivered. And part of what happens then is a positive feedback loop. So pressure from the head of the fetus to where the cervix is causes a message to the posterior pituitary that says to release oxytocin, which causes contraction of the uterus, which then pushes the head down further onto the cervix, which sends a message to the posterior pituitary to release oxytocin to contract the uterus. And this will keep happening until the stimulus is removed. And the stimulus is the downward pressure of the baby on the cervix. So once the placenta is delivered and everything is out of the uterus, then the stimulus to release oxytocin should go away. So we can make synthetic oxytocin, which is called pitocin, that will help increase contractions of the uterus for someone who isn't progressing or hasn't started labor. So this is a dangerous medication for the woman and the infant. When the woman has a contraction, during the contraction, when that uterine muscle contracts, there's decreased blood flow to the placenta, which means there's decreased blood flow to the baby, which is fine. That's how it goes. That's how normal labor and delivery is. And a healthy baby will bounce back from that stress every time there's a contraction just fine. But if the contractions are too close together or they last too long, then you're going to put the baby in distress because they're going to have far less blood flow, means less oxygen. So when a woman is getting oxytocin, they need to be monitored very closely for their safety, because they can have uterine injury, and also for the safety of the unborn child, because they might have a decrease in blood supply. So when you put somebody on oxytocin, you pretty much, what they say is tie them to the bed, because they need to be on the monitor. So here's the poor mom who's sad because she's having a baby, and their big pregnant belly will have then 2 monitors on it. One is monitoring contractions, and the bottom one is monitoring fetal heart rate. So, and that's hooked up to a monitor that everybody can see in their room and out at the nurse's station. How often is the mom having a contraction, and how long is the contraction lasting? And then with that contraction, there's an expectation that the baby's heart rate will decrease a little bit, but it'll come right back up once the contraction is over, because the baby can handle that stress. So we have to keep watching them to be sure that everything is okay. If the contraction lasts longer than a minute, or they're less than 2 minutes apart, then we're in trouble. One, that's too much stress on the woman's uterus, and it could lead to uterine rupture, which would be a surgical emergency. Or we're going to put the baby in distress, because that's not enough time to allow for blood flow. So this is an emergency when this occurs. And there is a proper way to go about it in terms of what am I going to do first? And so sometimes nursing students have issues with this because you think to yourself, well, I can do two things at once, or obviously this is an emergency, so 5 people are going to flood into the room and we're all going to do things together, which is completely true. But when you're answering the test question and when you're taking NCLEX or whatever, you have to remember what is the key first thing to do. And the key first thing to do is to turn the woman on her left side. If there's any concern, not even just with oxytocin, but any concern with fetal distress, what you want to do is take pressure off the woman's blood vessels to allow for cardiac output, which supports everything, the mother and the baby. So when you're turning the woman on her left side, you're taking the pressure of the uterus and the baby off of the inferior vena cava, which runs along the right side. So when the woman is laying on her back, or on her right side especially, there is compression on the inferior vena cava, so less blood is going to the heart. Therefore, the woman will have less cardiac output, and less cardiac output means less blood to the baby. So if I move and position the woman onto her left side, then I've taken all the pressure off the inferior vena cava, so she has good return to the heart and good cardiac output to support herself and the baby. So that's always the first thing that you're supposed to do. Turn her on her left side. Then of course you're going to turn off the Pitocin and you're going to put oxygen on to help get more oxygen to the infant. It's not for the mom, it's for the baby. So left side, that's what you want to do first. There are reasons why you wouldn't give the mother oxytocin, or things to consider not giving the mother oxytocin because of fetal concern. So maternal factors would be unripened cervix. If this is the cervix, it's still the 4 centimeter thick muscle. You can contract the uterus all you want. Nothing's going to happen except for injury to the uterus and the child. If the woman has an active infection in the vaginal area, you want to prevent vaginal delivery. So that would not be a reason to give oxytocin. So the example there is herpes infection, because that could lead to meningitis for the infant. If the woman has had multiple births or uterine surgery, her uterus has that increased risk for rupture, and that would be a reason not to give oxytocin. There are reasons that you wouldn't give oxytocin, certain fetal considerations. If the baby is not ready to be born because they're immature lungs, then we would try to stop labor. We wouldn't enhance it. If there was any fetal distress, then we don't want to put extra contractions or pressure on the uterus. And prolapse cord is another reason why there can be fetal distress, because if the cord actually slips down every time there's a contraction, the infant is also clamping the cord, compressing or tamponading the cord itself. So that would be a reason to stop labor, so we could fix that. Fetal malpresentation is a fancy way of saying breech, foot presentation or shoulder or elbow or whatever. People used to, back in the day, when it was not even labor and delivery doctors necessarily, it was your own family doctor, would just go in there with forceps, try to turn things around and stuff like that. Nobody does stuff like that anymore. That would be a reason to do a C-section now. Cephalopelvic disproportion means that the baby's head is larger than the woman's pelvic outlet. So it doesn't matter how many contractions you do, if you can't get the head through, it's not going to happen. So they would have to have a C-section. So you'll see on the slides that there's some information about Methergin, which is another uterine stimulant, which you might see on NCLEX. So the information is there for you, but it will not be on our exam. And then we have a uterine stimulant. And that medication is Terbutaline. A uterine suppressant. So this is a medication we would give in the setting of preterm labor usually, where we want to stop labor so that the immature, especially if the fetal lungs aren't ready, to increase the chance of viability, we would stop labor. So terbutaline is actually a beta agonist, which means it acts like epinephrine, norepinephrine on smooth muscle of the uterus. And during sympathetic nervous system stimulation, there is no uterine contraction because remember that's fight or flight. So it's not time, we said it's not time to pee or poop before. And we also would say that if I'm getting chased by a saber-toothed tiger, it's not time to start labor and delivery. So that's wise. It's a good idea, body. I do not want to go into labor if I'm in trouble. So if I activate the sympathetic nervous system's action on the uterus, then I can decrease or stop contraction. That's the whole point. So, and I want to give the infant time to mature their lungs. And in the meantime, because you can only prolong or stop labor for so long before it starts back up again, you can give the woman steroids and surfactant to try to do things to speed up lung maturity. So we know that because it's a beta agonist, that action on the uterus is to prevent contraction. But beta agonists, we wanted it to act just on the beta 2 receptors of the uterus, but we know that no drug is completely clean and that there are other beta receptors in the body, namely the lungs, but that promotes bronchodilation to let air in. And so sometimes actually terbutaline is a treatment for asthma, an emergency. The other things are the things that we can think about that occur with albuterol, which is also a beta agonist, where the person has tachycardia and tremors. Those can be the big adverse effects that can occur if the person develops arrhythmias, especially. So we want to confirm that the woman is in preterm labor, that it's too early. So if she was over 35 weeks, I mean, they might just let it go and be sure that, and try to be sure that the infant is taken to NICU right away or whatever. If the person is less than that, then you're trying to stop the labor if you can. It's given sub-Q every 20 minutes for up to 3 hours. You can't do it for longer than 48 hours. You have to watch the fetal heart rate and the maternal heart rate because it's a beta agonist and both the infant and the mom have beta receptors on their hearts. They can both end up with tachycardia, which would be a reason to stop. So it says there, if the fetal heart rate is above 180, that's a reason to stop the medicine. Briefly, eclampsia is a condition where the woman has high blood pressure and is not removing toxins. Her kidneys aren't working as well, which puts her at increased risk. That's preeclampsia, which puts her at increased risk of eclampsia, which is seizures. So they have increased action potential or potential for seizures. So if that's occurring, you would give electrolyte to change the resting potential between the inside and the outside of the cell. So that is often used in the perinatal period to treat or prevent seizures for a woman that has preeclampsia.